My name is Laura Hooper from AOTA, and in part 2, I'll cover barriers to benefit implementation, real-world barriers that keep people from accessing the promised benefits. I'll also describe a joint statement developed by the 3 therapy groups comprising a list of principles for benefit design and implementation. Our joint statement asserts that habilitative and rehabilitative services and devices are essential parts of comprehensive health insurance, and occupational therapy, physical therapy, and speech therapy are the foundational services in any habilitation and rehabilitation benefits package. The original impetus to develop this statement was in response to a proposed change in the way CMS was implementing the essential health benefits, EHBs, giving states an annual opportunity to adjust the benefits covered under the 10 EHB categories. But we soon decided that we needed a set of principles for benefit design and implementation for all public and private insurers, employers, and consumers. This joint statement was released in 2019 and updated in 2021. The joint statement endorses the following definitions developed by the National Association of Insurance Commissioners, NAIC, and adopted by the Departments of Health and Human Services, Labor, and Treasury for an ACA-mandated consumer glossary of health insurance and medical terms. Rehabilitative services help a person keep, get back, or improve skills and functioning for daily living that have been lost or impaired because a person was sick, hurt, or disabled. Habilitative services help a person keep, learn, or improve skills and functioning for daily living. Teaching baby care skills to a new mother with multiple sclerosis would be providing habilitative services. Helping her recover from an injury incurred during a flare-up and fall would be providing rehabilitative services. By promoting these definitions of habilitation and rehabilitation, our statement advances the principle that therapy benefits should include services to attain and maintain, not just regain skills and functioning. As Kate explained in part 1, the ACA established a focused and protective category for therapy services in the rehabilitative and habilitative services and devices EHB. But almost 10 years after the ACA marketplaces went live, and more than a decade after the EHBs were established, we're still working to fully implement the rehab and HAB benefit category. Coverage under the ACA marketplaces and essential health benefits began on January 1st, 2014. States determined the specific services covered under the EHB categories by selecting a benchmark plan that served as a model. At the time, habilitation was the new benefit. Most existing plans didn't identify them as a distinct group of services, and the lack of a standard national definition led to a benefit that was variable and gappy. Recognizing the need to minimize the variability and lack of coverage of habilitative services, CMS established a uniform definition of habilitation, which took effect in 2016, and separate visit limits for habilitation and rehabilitation, which took effect the following year. They adopted the definition from the consumer glossary developed by the NAIC as a national floor for coverage that would be in effect in the absence of a state definition. In 2020, the rules changed to allow states an annual opportunity to select a new EHB benchmark plan. This year, CMS introduced several changes with the potential to ease access to rehab and HAB services, including standardized plan options with favorable benefit design for therapy that attracted 20% of enrollees. Key features of these plans include cost sharing for therapy that's the same as a primary care visit, pre-deductible coverage for OT, PT, and speech, and a predictable copay, not coinsurance, for therapy services. The marketplaces also introduced first-time network adequacy standards for OT, PT, and ST, and new non-discrimination standards for the EHBs, which added an explicit requirement that benefit limitations and coverage requirements be based on current clinical evidence. An example of the new non-discrimination protections at work: Maryland issued a bulletin in March instructing individual and small group plans to delete visit limits for habilitative services for adults, citing the new enforcement framework. Under this framework, benefit limits based on age are considered presumptively discriminatory if the services are clinically appropriate for all ages. In healthcare, the term relevant to almost all resources is medical necessity, and medical necessity definitions tend to focus on treatment to recover lost function, which can be a barrier to therapy services for people with chronic conditions. Our joint statement endorses the definition of medical necessity from the consumer glossary developed by the NAIC. In a recent request for information on strengthening the essential health benefits, AOTA suggested making this the official definition of medical necessity for the EHB. By establishing that medically necessary services include services that help keep, learn, or improve skills and functioning, this definition would overrule limiting language such as recovery of lost function or restoration to a previous level of function. We want all kinds of health insurance to affirm that rehabilitative therapy and habilitative services are allowed for individuals with chronic progressive conditions to prevent further deterioration of function and remove language that diminishes the value of therapy services for people with disabilities and chronic conditions by excluding services that are long-term or maintenance in nature, not subject to improvement, not result in change for the better. These limitations are inconsistent with Medicare policy toward maintenance therapy, which, as Kate explained in part 1, became a covered benefit in Medicare via a lawsuit. The 2013 JIMO settlement agreement clarified that skilled therapy is covered to maintain function or slow decline, But 10 years after Medicare eliminated the improvement standard on paper, maintenance therapy remains underutilized. Barriers to fully implementing the change include lack of practitioner knowledge. Practitioners may not be aware that maintenance therapy is permitted. And as Kate explained, there's an additional medical review threshold of $3,000, and any individual beneficiary who has claims that exceed that amount is potentially subject to medical review, which could be a deterrent for practitioners. To fully implement this policy, we can continue to educate stakeholders on the repeal of the improvement standard and on appropriate and descriptive documentation for justifying maintenance care. We also think that implementation of a plan's benefits shouldn't be unnecessarily delayed or impeded by utilization management. Prior authorization requirements and utilization management companies can sometimes impose a one-size-fits-all model of service approval. We need to look at each patient, or at least each condition or stage, individually. Prior authorization may be required to initiate therapy or to keep providing services after a patient receives a set number of visits, hours, or units of therapy. Our members frequently report that prior authorization is a cause of administrative burden, places providers at risk of non-payment, and can delay patient care. The paperwork requirements may deter providers from requesting further visits, effectively turning soft limits into hard ones. Some states have laws constraining prior authorization, such as by requiring insurers to publish clinical criteria online and establishing timelines for prior authorization decisions. In Medicare Advantage, a 2018 report from the HHS Office of Inspector General found that plans overturned 75% of pre-authorization and payment denials that were appealed by patients and providers. And a subsequent report in 2021 found that 13% of prior auth request denials and 18% of payment denials should have been approved. A proposed rule under consideration right now, advancing interoperability and improving prior authorization processes, aims to streamline prior authorization in the 3 M's, Medicare, Medicare Advantage, Medicaid, and the ACA marketplaces, but would not apply to the 150 million people with employer-sponsored coverage. If finalized, it would establish a standard interface for prior authorization request, shorten time frames for decisions, provide specific reasons for prior authorization decisions to patients and providers, allow prior authorization approval to remain valid when a patient changes plans, and post prior auth metrics, including percentage approved and denied, and denials overturned on appeal, and average wait times on payer websites. In Medicare Advantage, CMS recently finalized changes to address service approval criteria, clarifying that MA plans must follow the same coverage guidelines as traditional Medicare for basic benefits. When Medicare coverage guidelines aren't fully established, they can only use internal criteria for medical necessity decisions if they're based on evidence-based guidelines that are made publicly available. It also requires authorizations to last through an entire course of treatment and remain in effect through a 90-day transition period if a person switches plans. Our statement also says that plans should maintain an adequate network of qualified providers to furnish skilled rehabilitation and habilitation for covered needs, and maintain networks that are broad enough to ensure consumer choice and availability of qualified providers with the skills to treat the full scope of conditions, illnesses and injuries, and other covered issues that can benefit from rehab or HAB. In 2023, the ACA marketplaces added network adequacy standards for therapy services in the form of federally enforced time and distance requirements. For example, in a large metro county, plans will have to prove that 90% of their enrollees can reach an in-network OT, PT, or speech provider within 10 miles and 20 minutes. Time and distance standards can gauge whether participating providers are geographically accessible to plan enrollees. They don't measure network breadth. And reimbursement rates are a key driver of provider participation, and professional associations are interested in securing sound payment policies for our members. In part 3, Becky will describe the multiple procedure payment reduction, MPPR, which reduces payment when multiple procedures or units of therapy are provided to one patient on one day in one setting. Nebraska is one state in which multidisciplinary state-level advocacy got a law passed prohibiting the use of this methodology in Medicaid. Other examples include therapy assistant modifiers that reduce payments 15% or more when services are furnished by a PTA or OTA. Like MPPR, this is a Medicare policy that's been adopted by some state Medicaid programs and private payers. And we're also concerned when codes used to bill for common therapy interventions are excluded. For example, a few years ago, AOTA did outreach to a handful of state Medicaid programs that didn't allow us to bill 97535, self-care and home management. Now I'll pass it to Becky to talk about the Therapy Association's advocacy to remove barriers to coverage and improve payment.